everybody. I am Aritra Bose. I am a research scientist at IBM Research. And today I'm going to talk about race versus genetics in clinical decision making. Essentially, how can we use genetics and in terms of racial classification categorization to aid us in clinical decision making. And we're going to get this perspective particularly from cardiovascular diseases. This is a collaborative work from the healthcare and life sciences group at IBM Research. We historically we have known that the American Heart Associations and other associations, they have guidelines in place for race correction algorithms for clinical decision making. And recently, it has been shown that these race correction algorithms are often inaccurate, and we posit that with the treasure trove of information from genetics now with these large biobanks, we should be able to make better decisions in a clinical setting in healthcare by being informed on the idea of race from a genetics perspective, right? So we asked the question that is there a biological reason for suppressed cardiovascular disease in certain races? Or is there a bias in how a patient was treated, right? So in terms of diagnostics and therapeutics. And how do we find such biases? By asking some epidemiological questions. So this talk will be a playbook of kind of teasing out this bias in such an observational cohort linked with genetic information, such as UK Biobank, right? And would using genetic information in terms of population structure or polygenic risk score would lead to better decision making, right? So these are the essential questions that we are going to deal with in this presentation. And in terms of background, there was a seminal work by Vyas et al. In New England Journal of Medicine, which talked about reconsidering the use of race correction algorithm, and this is where this work is inspired from. And we see, obviously, a lot of you know that Blacks are more likely to die with respect to heart diseases, and when correcting for gender and social issues, and they're also more deprived socially. So, and in terms of socioeconomic status, cardiovascular diseases have a strong link with the environment and well-being of a individual, inspired from diet and from their social conditions. And also, there have been a lot of discussion about race affecting heart diseases, right? So, and this white paper from University of Chicago School of Medicine talks about race being a social construct, as we all know, and the social construct is often inspired from their cultural conditions, their socioeconomic conditions, their social status, and an exposure to certain things, which which in tandem puts an individual at risk of cardiovascular disease outcome versus other racial groups who are more probably who enjoy a better position in terms of socioeconomic status in the society. So we obtain all these insight in this presentation from mainly from UK Biobank, and we, for hypothesis forming, we also considered the Exploris data. So UK Biobank obviously is based in UK. It has a lot of genomic information, and some of the hypotheses that we formed were we also use Exploris data, which is based in United States, but it does not have any genetic information. So the outcomes that we considered here are mostly coronary thrombosis, which is we combined different cases of myocardial infarction to form coronary thrombosis phenotype, and then obviously also focusing on other related cardiovascular disease like comorbidities such as hyperlipidemia and hypertension, etc. And we also considered a lot of variables such as BMI, age, etc., which explain the demographics and socioeconomic status for different individuals in this cohort, right? So we find that being Black is a risk for metabolic syndrome related issues. It has a higher risk for hypertension, type 2 diabetes, obesity, and this is all based in US. This is based out of the Exploris data. And it has a protective effect on hyperlipidemia, coronary artery disease, and mortality due to myocardial infarction. And also, it has a relationship with the socioeconomic status, both in the US and the UK. So in the explorers, we have for AMI fatality risk, with respect to socioeconomic status, we have an OR for 1.26, and it increases by or almost doubles when we consider the UK. So with this in mind, in UK Biobank, we find that there is a difference in UKBB outcomes with respect to races and also to enrollment bias, right? So Black British and other minority populations, they in general have a fear of healthcare, right? And they do not have accessible healthcare always in different places, where the white populations, the people who are in the upper echelons of the socioeconomic status, they enjoy that privilege of being closer or to being accessible to healthcare, and that is reflected largely, right? If you add all these, so this is all cardiovascular disease related comorbidities on your left hand side, right? And if you add all these participations up, you will at least get like to around 10% for diabetes, which is very common, right? So that shows that the enrollment bias in diabetes is large. This 90% of populations are actually white who are diabetic in UK Biobank, and thus Black British and other non-white populations are heavily underrepresented. And as it is in diabetes, obviously it reflects more gravely in other cardiovascular disease related comorbidities, which are a bit rarer than diabetes, right? And we also found out that Black populations of Black British are at a higher BMI than other populations, other non-white, non-Black populations, and also in terms of Townsend deprivation index, which is an index which reflects on how deprived a person is. Black individuals are more deprived than other non-Black individuals in UK Biobank. So starting from that, we try to obtain some of these epidemiological insights into teasing out bias in UK Biobank, right? So we wanted to predict Black British status, the ethnographic category of Black British, from cardiovascular disease-related comorbidities in terms of therapeutics and also diagnosis, right? So we find that Black British have a protective effect on coronary thrombosis, and in hypertrophic cardiomyopathy, they are more at risk. And for example, in other social conditions such as TDIs, as I showed before, they are at higher risk. So we could predict Black British from some variables such as Townsend deprivation index, such as their use of calcium channel blockers, and also in hand with that, their status of being hypertensive. But if we want to predict coronary thrombosis or coronary cardiac fatality diagnostics from their Black British cohort, we do not really find a very distinct kind of association where we have similar patterns, and obviously, both for coronary thrombosis and cardiac fatality. And then we ask the same question in terms of hyperlipidemia diagnosis as well as therapeutics. For therapeutics, people who were prescribed fibrates or statins for hyperlipidemia, we ask whether we can predict the status of being prescribed a fibrate or a statin prescription who are hyperlipidemic, right? And whether we can tease out some racial associations with that. We find that the status of being South Asian it puts you at risk towards more hyperlipidemia therapeutics, and the associative term of obesity and being Black British kind of puts you at higher risk for being prescribed of hyperlipidemia statins or fibrates, but the isolated ethnographic categorization of being Black is not really associated, right? And similarly, we also find the same from hyperlipidemia diagnostic, right? So we find that being Black doesn't really tell a lot about whether you are likely to be hyperlipidemic or not, right? But if you are hypertensive, obviously it talks a lot about being hyperlipidemic. Right? So we corrected for that, and we obtained that being Black is actually a bit protective for hyperlipidemics. But if you mind the error bars here, they're huge because we have a lot of less number of Black individuals who are hyperlipidemic or who have some kind of cardiovascular disease-related comorbidity, right? So then we ask a separate questions of whether predicting coronary thrombosis from comorbidities in Black British versus non-Black British. And this is kind of our main question that we sought out, right, to ask that whether we can predict coronary thrombosis diagnostic status from race alone, right? So if Black British people are more likely to have coronary thrombosis cases, but in this case, we cannot tease them apart. So they are similar in terms of just using the ethnographic classification of Black British, right? So they have the similar trend, and obviously the error bars again are pretty huge in Black British versus they're negligible in non-Black British, right? So that with that in mind, we created a cohort to actually do some genetic analysis and aid our epidemiological questions from genetics. We focused on coronary thrombosis, as I said before, combining the ICD codes of acute myocardial infarction and subsequent myocardial infarction. And we focused on a cohort of 42,500 individuals where we balanced them across their of being white versus non-white. So we sampled the maximum number of non-white populations in UK Biobank, and then we equated that with a representative population from the white individuals, right? So, and these are the distributions for all these individuals. So you can see that we have about like 7,000 Black individuals, and among those 7,000 Black individuals, we have about 150 individuals who are coronary thrombosis cases. So I'm showing you the PCA in top right here, and you can see a triangular structure in the PCA. So this is the genetic structure of this particular cohort of 42,500 individuals, where in this triangular structure, each vertex represents a population. So the vertex in your lower right corner are the Black individuals, lower left corner are the white individuals, and in the top vertex, they reflect the Asian individuals with two subgroups of East Asians and South Asians. And we overlaid coronary thrombosis cases in Black on top of all these individuals. And you can see that they are almost ubiquitously present across all these vertices in this particular triangular structure. So then we asked the question whether there's a strong association between Black British and the principal components, or the PCs obtained from this PCA. And we find out that the first principal component absolutely explains the variable of ethnographic classic category of Black British. Right? So then obviously we ask the question that, can we replace the Black British ethnographic category with PCs and obtain some more information, right? And we find out that we don't really obtain more information in terms of replacing just the ethnographic category with the PCs, which explains a lot of that category, right? So genetics with just population structure in it doesn't really explain a lot in terms of they are predicting whether they are more likely to be coronary thrombosis cases versus not. And then we posit that if we use predisposed genetic risk for coronary thrombosis, so in the previous experiment, what we did was we replaced the ethnographic category of Black British with the top PC, which explained so with genetics, right? But now we posit that what if we do the opposite thing? So so we replace the coronary thrombosis disease phenotype category with PRS, or polygenic risk score, for coronary thrombosis. Can that lead to a more nuanced exploration on the epidemiological question that we are asking, that whether they are more likely to be related with Black British versus not, right? And with that in mind, I'm just going to give you a little bit of explanation of PRS here. So just how to interpret PRS. So in this distribution, when you look at the long tail towards the end, we are at higher risk of a particular disease, right? So I'm showing this for hypertension with this bell curve. If you are looking at the V end, you are going to look at more hypertensive patients versus looking at the other end where you are least hypertensive patients, right? So that is how you interpret the bell curve. So as you progress, you obtain more at-risk populations. And the PRS is usually computed from a GWAS and validated in a discovery sample data, which is different from the base cohort from where the GWAS is computed. And then we find that asking the previous question of whether they were associated with Black British for a coronary thrombosis diagnostic status for a phenotype, we find that if we replace the diagnostic status with the PRS for the coronary thrombosis, black individuals are more at risk. And with the increasing decile, so as we go towards the end of that distribution, we obtain more individuals who are at risk and who are actually Black British. So there's a high correlation or rather association between Black British individuals and higher PRS, so higher at-risk individuals. So that shows that if we replace the coronary thrombosis diagnostic phenotype with PRS, so genetic predisposed genetic risk for that particular phenotype, we can obtain more information about how it deals with how it connects with a certain race versus others, right? So similarly, to summarize what we did, right? So non-white populations such as Black, Asian, and mixed ancestries are heavily underrepresented in EcoBiobank, and the genetic population structure is not enough alone to tease out the the relationship between whether a Black British individual is more at risk of coronary thrombosis or other cardiovascular disease-related comorbidities. But if you replace the phenotype with the PRS of that phenotype, then it shows that it has a more nuanced effect on the racial categorization of Black British or other non-white populations. So just to conclude what we found, African ancestry in UK is very complex, as is the continent, and it is notoriously understudied. If you want to know more about non-white individuals and their predisposed genetic risk, we need to sample more of these populations, right? And that British have lower rates of diagnostics for hyperlipidemia and other cardiovascular disease-related comorbidities, and the cardiovascular disease-related diagnostic rates are similar to the hyperlipidemia diagnostic rates, both for Black British hyperlipidemics and for non-Black British hyperlipidemics. So hyperlipidemia is not enough to tease out these biases that in clinical decision making. And also, if we are looking at just the diagnostic disease phenotype, it is not enough to tease out these biases, and we need to have a more informed, genetically informed phenotype of the PRS, for example, as a proxy for those phenotypes to tease out of more of these biases, right? So which the phenotype of just the disease classification fails. And the main takeaway of this talk, as I was saying before, that Black adults are more likely to die from COVID than other individuals in the US. And the current genetic association studies cohorts, they are mostly still heavily skewed towards the European Caucasian populations, both across all the studies and all the individuals studied in the GWAS catalog, which is a public repository, and there's a very less representation of African or other non-white individuals in those cohorts. And we need to be more inclusive in recruitment or in these EHR-linked biobanks, and we need aggressive efforts of risk assessment and risk factor control, and understand nuances of the communities at elevated disease risk, and also their social implications and how we can define these underrepresented minorities in terms of their environment better that we have been doing in the past. And we need to have informed decision making from genetics, not just looking at racial categorizations or disease phenotypes, but we need to involve genetics in this conversation of clinical decision making. So that is probably the most important takeaway. And this is a call to action for all of you who are interested in this to create more equitable healthcare, to focus on non-white populations in research more than what you have been doing in the past. Thank you. I want to thank my co-authors in this. And if you have any questions, now would be a great time to ask them. Thank you.